Hello, my name is Dr. Jonathan Howard, and I am a neurologist and I am a psychiatrist at Bellevue Hospital and NYU here in New York City. I am also a regular blogger for the blog Science-Based Medicine. And today I thought it'd be sort of fun and interesting to do something I've never done before, which is to turn a camera on myself and record myself discussing my most recent science-based medicine article. What I'm going to do today is I'm mostly just going to read it. I'm going to offer some additional commentary based on some of the links that people cannot see for themselves if they choose to listen to this as opposed to read my blog. So you're probably not going to get too much additional stuff from listening to this as opposed to just reading what I wrote. But a lot of people, myself included, enjoyed listening to podcasts while we're at the gym or driving, although I don't drive here in New York City. I'm kind of lucky that way. So if you're someone who prefers to listen instead of read, that's what this is all about. And we'll see if this is something that I like doing and people seem to enjoy listening to. Maybe I'll make it a regular thing. Maybe I won't. Who knows? If you do like it, please hit the like button, hit the share button, or don't hit the like button, don't hit the share button. I don't really care. I'm just going to see if, like I said, if I enjoy doing this and people enjoy listening to it. And the article that I'm going to discuss today will be published on May 5th, 2023, and it is called Letter to a Medical Student. There is no elite RCT strike force. Just a little bit of background. This article is going to be about something called methodolatry, even though I don't use the word in that essay. I did write about this topic exactly 1 year ago, May 2022. So I encourage anyone who's interested to go to Science-Based Medicine, click on my name, click back on my articles that I wrote last year, and find this article about methodolatry. And what methodolatry means, what it's defined as the worship of randomized controlled trials as the only way that we can learn about medicine. And in that first article, I go through, I make several points, which I'm going to flush out here today. But I make the point that, yes, randomized double-blind placebo-controlled trials are the gold standard in medicine. This is the ideal. This is what we want. But you can't study everything that way. And this letter that I'm going to read now is a response to a medical student who wrote something on a blog, which I will sort of discuss, called Sensible Medicine, where I will deviate from what I have written and what I will add in this podcast is, I think, just discussing some of the links in the essay and really sort of expounding on them and why I included them. All right, so without further ado, let us begin. Dear Mr. Knudsen, I read your article on Sensible Medicine titled Death and Isolation During a Pandemic. You wrote movingly of your grandfather's death and reflected on the tragedy of people dying alone at the start of the pandemic. As someone who lived through it all, I couldn't agree more. Anyone who worked in a hospital at that time remembers patients suffering without their loved ones and aching goodbyes via iPads. It happened to an overwhelming number of families who will be forever scarred. I'll never forget one father who screamed at us that we didn't try hard enough to save his 35-year-old son. Had he been there, he would have at least had the comfort of knowing we did everything possible. His son had blood clots throughout his body, and there was nothing more that we could do. How horrible that he believes his son might still be alive, had only we tried a little bit harder. And a couple of the links in that paragraph, one of them goes to an article that was written about a year ago called Forcing My Patients to Die Alone is Inhumane and Unnecessary. And I hope that people read this article because it really does go into the detail of how much suffering there was for patients, COVID patients who were by themselves, elderly, delirious, without a loved one there. And of course, the families at home, suffered a great deal as well. So it was a really horrible time. And I mean it that everyone involved will be forever scarred. Back to the letter. However, Your article contained one very problematic paragraph. You wrote, and I quote, "Even with reasonable predictions, we live in a world that is messy and random, and thus require rigorously designed studies to uncover one form of truth. I imagine that a cluster randomized controlled trial could have provided an answer. This would have consisted of randomizing hospitals into two groups, one that allows visitors and others that restrict them. Then, over time, outcomes would be tracked in each group to measure the impact of the policy. I specifically left outcomes vague because the pertinent outcomes are debatable, but I would argue that a good starting point is COVID-19 hospital admissions. Another relevant outcome may be the number of positive COVID-19 cases in the surrounding community, although this would be more difficult to directly link to the policy. The broader point being that there are ways to uncover answers. There are smart people in positions of power with resources that can design and conduct such studies. Ultimately, they failed us, and we are left without answers and policies that caused significant harm." And that last paragraph was in bold, or excuse me, that last sentence was in bold. Ultimately, they failed us, and we are left without answers and policies that cause significant harm. And throughout that essay, throughout my essay, I bolded the use of the word they, just like the author of Sensible Medicine did. And back to the article. It might not seem so, but there's a lot to unpack here. We both agree that randomized controlled trials are the gold standard in medicine. So how could I object to your call for a rigorous RCT to answer an important question? To answer that, I'm going to do something that the doctors behind Sensible Medicine obviously didn't do. I'm going to respect you and take you seriously. So another little timeout from this essay. Sensible Medicine is a Substack blog run by doctors who call themselves medical conservatives, Vinay Prasad, John Mandrola, and Adam Sifu. And I've written a lot on these doctors before, especially doctors Mandrola and Prasad, who I think spread a lot of misinformation this pandemic, ranging from declaring it over a dozen times to treating rare vaccine side effects as a fate worse than death. And I do mean that fairly literally. Making basic factual errors. For example, although during this pandemic, over 2,000 children have died of COVID and under 200 children have died of the flu, they have all said that flu is bad for children as COVID or even worse. So I think that they've made a lot of factual errors, and they have allowed medical students, this is not the first time, to write articles that I think are substandard, and I think that they're doing a disservice by allowing medical students to publish these sorts of essays. So back to the letter. First of all, who are they? And again, he bolded that, I bolded it. So who are they? Whom exactly did you have in mind when you wrote, "There are smart people in positions of power with resources that can design and conduct such studies"? You seem certain that someone had the time, resources, and authority to run your imagined RCT, but they just chose not to for some stupid reason. Incredibly, you also think they should have had the foresight to run your imagined RCT, as morgues overflowed with victims of a new virus that lacked treatments and a vaccine. You think they should have been marshaling their resources, conduct a randomized controlled trial of hospital visitation policies of all things, as if there were no bigger fish to fry at the start of the pandemic. Of course, your imagined RCT would have sounded utterly absurd at the pandemic start, which is why nobody actually suggested anything like it at the time. So there's a lot of people in the comments to this article who are saying, yes, they should have done this. They should have done this. How stupid were they? No one was thinking about this 3 years ago in spring of 2020. Back to the letter. You see, unless you know something I don't, there isn't a well-funded elite RCT strike force that's been training for a pandemic. Though when a real virus arrived, they sat on the sidelines doing nothing for no particular reason. You seem to think that a large group of people with a relevant medical expertise were really lazy. Who exactly do you think spent the pandemic twiddling their thumbs? Maybe there should be an RCT strike force, but the cold truth is no government or no institution anywhere could have instantly whipped up dozens and dozens of rigorous RCTs to answer every pandemic conundrum and quandary as you seem to imagine. In the real world, politicians meddled with scientific agencies, and the CDC couldn't even get basic tests right at the start of the pandemic. Much of the federal response was in shambles from the pandemic's earliest days. You should read about it. According to one recent article, and the link here goes to a Washington Post article, which describes another, which is about a pandemic report that was just very recently published. And the Washington Post article says, early on, the government went off the rails. In February 2020, the focus was on containment with measures such as the travel ban on China and repatriation of Americans, including those stranded on cruise ships. Emergency mobilization efforts languished, the report noted. There was confusion and restriction about who was in charge of what problems. The government's crisis action plan amounted to little more than jargon. There was little in it about what people actually would do. On February 24th, 2020, President Donald Trump tweeted from India, "The coronavirus is very much under control in the USA. Stock market starting to look very good to me." But according to the report, that same day, the White House task force concluded, quote, containment was failing. It was time to shift to mitigation. The next day, a high-ranking Centers CDC and prevention officer, Nancy Messonnier, I'm sorry if I'm butchering these names, announced that community spread in the United States was inevitable. The stock market dived. President Trump was furious, the report recalls. He kept downplaying the danger. It's going to disappear, he said on February 27th. Everything is under control, he said on February 29th. It was not. The authors of the report show in detail how federal crisis management, quote, splintered by the third week of March. HHS Secretary Alexander Azar had placed the Assistant Secretary for Preparedness and Response, Robert Kadlec, in charge of the HHS effort, but at the same time, Vice President Mike Pence's staff kicked him off the White House task force. The head of the Food and Drug Administration was not even on the task force for the first month. The CDC was fractured into too many missions. While some officials recognized the urgency of a crash program of testing and masks, quote, Kadlec had no money and no real emergency fund. By late April, as a frightened and bewildered country became more and more confused about continuing business and school closures, and after somehow brow-raising comments at the White House briefing in which he discussed treating the virus with light, heat, or disinfectant, Trump essentially detached himself from his own government, the report says. He moved towards questioning and challenging what other government officials were doing. The administration abdicated its wartime responsibility to lead, they added. It left the battlefield and the war strategy to the states and localities. By April, the White House Chief of Staff concluded the task force was, quote, useless and broken. So that ends the quotation part from the Washington Post article. But this is who you imagine had the power, resources, and competency to have carried out your imagined RCT at the start of the pandemic. They are they. Even if they had an elite RCT strike force at their disposal and bizarrely prioritized your imagined RCT at the start of the pandemic, it still faced many obstacles. I agree that COVID hospital admissions would be a reasonable outcome to track, but a woman who visits her sister at Hospital X isn't necessarily going to be admitted to Hospital X if she contracts COVID herself and needs to be hospitalized. At Bellevue, where I worked, nearly all of our patients were transferred from other overwhelmed hospitals. You should read about it. As such, your study would require that hospital visitors be followed and their hospital admissions tracked. And the link here goes to just a very straightforward article showing that at Bellevue, we were taking 40 to 50 patients a day from other overwhelmed hospitals in Queens. Back to the article. I'm not an expert in this area, but it sure seems to me that your imagined RCT would require informed consent for every hospital visitor. How would a grieving family feel if they lost another loved one and only later learned that she was infected at a hospital that was part of a medical experiment to which she did not consent? Doesn't she have the right to know about the risks of your RCT, which include death, before she participates in it? At least one Twitter commentator had this to say about your proposed study. And here I'm going to quote from a fairly lengthy Twitter thread by someone named Cassandra Complex. Obviously, I have no idea who this person is or if they know what they're talking about, but they definitely seem to know to me what they're talking about. And they said the following: the logistics of conducting such an RCT at that time would be absurd, both to both staff and disproportionately visitor burden. But yes, an IRB, which I'll discuss in a second, any IRB worth convening would require every visitor to review a consent form that presents research aims, data, collection, handling, and follow-up, specify the voluntary nature of participation, and if a visitor opted in, they retain the right to opt out at any time. Refusal to participate would not impact care or services they or their loved one would otherwise receive at that institution. Anyone who refrained from opting in would need to be marked for removal for the data set. Their information, no matter how de-identified, would need to be discarded, regardless of how important they'd be to the research aims. If any opted out visitor's disposition is later learned by the research team by hearsay or happenstance or whatever, the opted out visitor's outcome cannot be added to the final data set for analysis. Based on that screenshot, which was just the paragraph that I read to you at the beginning from the student's essay, what is being proposed would not meet criteria for exempt IRB review. It likely wouldn't mean expedited review either. Do you disagree with that? This person ended their Twitter thread by saying, the author of that blurb should have all of their past contributions to field research reviewed for breaches of consent. Consenting and tracking every visitor at multiple hospitals while COVID raged would have been a Herculean task. Again, who exactly had the resources to do this? Such expertise can't be conjured out of thin air in a matter of weeks in the middle of a raging pandemic. There's not an endless supply of clinical research coordinators. Why should these skilled professionals, and they are skilled professionals, have dropped everything to run your imagined RCT? Thankfully, they chose to prioritize vaccine RCTs. Many more questions and challenges remain. Like I said to the student, I'm going to take him seriously and really think about his proposal, something the doctors behind Sensible Medicine certainly didn't do. So some more questions and challenges. Would hospital administrators have let their hospitals participate in your imagined RCT? I doubt it. An RCT of hospital visiting policies wouldn't have been on their radar at the start of the pandemic. They were too busy trying to get PPE, trying to get staffing, trying to find places to put patients, dealing with transfers, and places to store the dead bodies. If you had walked into my hospital administrator and said, hey, we want to do an RCT of hospital visiting policies, you wouldn't have even gotten in the door at the start of the pandemic. Would multiple hospital IRBs have approved a study that allowed a large number of unvaccinated family members into unventilated rooms full of contagious COVID patients at the start of the pandemic? So I assume probably most of you know what an IRB is. It stands for Institutional Review Board, but they're basically sort of a group of people connected to a hospital who have to approve medical research to ensure that nothing dangerous is being done, that the research is ethical, and that the research is important, and that the research needs to be done. Back to the essay. As morgues overflowed and forklifts were needed to move corpses into refrigerated trucks, would an IRB have actually accepted that there was true clinical equipoise and that your study needed to be run at that moment? I'm skeptical. For those who don't know, clinical equipoise really just means that we're sort of uncertain. So it would be unethical to run a study. The sort of prototypical example is it would be unethical to run a randomized controlled trial of parachutes because no one really doubts that parachutes work. So in order to run an RCT, there sort of has to be genuine uncertainty about what the effect of the policy would have. And I don't think at the start of the pandemic, there would have been too many people who said, yeah, you know what, we really don't know if there's going to be any problems letting a bunch of unvaccinated people into rooms full of contagious COVID patients, and all these people are mourning and crying. What could go wrong? So I'm very skeptical that this would have gotten IRB approval. Back to the essay. I work at two hospitals, NYU and Bellevue, that are blocks apart in terms of their distance, but worlds apart in terms of the patients they treat and the communities they serve. To control for these discrepancies, you would have to enroll a large number of hospitals. How many hospitals would have to participate to get meaningful results? What would happen to your study if some dropped out? What if hospital staff objected to your study? At my hospital, we are packed like sardines on elevators on a normal day. Your imagined RCT would have greatly increased our exposure to the virus at a time when no one was vaccinated. I wouldn't have been thrilled to have been randomized to the visitors allowed hospital. We had enough sick healthcare workers as it was, and several of my co-workers died. You should read about them. Why didn't you factor us into your imagined study? What if the general public objected? Allowing hospital visitors would have meant more people on subways and buses, and therefore more risk for the essential workers who used them. You should read about their experience. Would these unvaccinated workers have had any input into your study? And there I linked to a study of a bus driver in Detroit who got very angry when someone coughed on him at the start of the pandemic in April 2020, and he died 11 days later. So, having a bunch of unvaccinated people traveling back and forth to the hospital on public transportation would have increased the risk for the general public as well. Back to the essay. Many hospitals were deluged with COVID patients in the spring of 2020. You should read about it. It's not unreasonable to imagine that large groups of mourners in a hospital room would have greatly increased the spread of COVID in the spring of 2020. What contingency measures would have been in place if your study caused a lot of people to be hospitalized when hospitals were already overwhelmed? Did you even consider that possibility? Might patients and their families preferentially choose to bring their loved one to a hospital that everyone knew was randomized to allow visitors? And how would this affect the results? Would a trial conducted in the spring of 2020 have any relevance today? I don't think so. Both the population and the virus itself have changed too much. The original vaccine RCTs, which were published in the spring of 2020, they became obsolete in less than a year with the arrival of Delta and Omicron. Why would your RCT age any better? How long would your study have taken? Here in New York, where we had some of the strictest policies, hospitals were mandated to allow visitors June 2021. So basically, the visitor restrictions lasted less than a year, and lasted about a year here in New York, and a lot of hospitals got rid of them voluntarily on their own before then. So do you really think your study would have yielded actionable results before this? I doubt it. Would you or anyone else support visitation restrictions today if your study found that hospital visitors increase the spread of COVID? Even RCTs that yield an unambiguous scientific result rarely allow us to agree on what policy should flow from them. They almost never provide a crystal clear answer to complicated social and ethical questions such as hospital visitation policies during a deadly pandemic. Let's pretend your study found that allowing visitors increase COVID infections by 14.3%. I just made that up. Should hospitals allow visitors or not based on that number? Would everyone agree with your answer? Are you certain that your imagined RCT won't interject uncertainty and polarization into this very rare issue where there seems to be near uniform agreement today? I'm not sure exactly when the policy of restricting visitors should have ended. I don't. But like everyone else, and I mean everyone else, I'm glad it's gone. So even if your study were perfectly and rapidly executed at the pandemic start, how long would it have even had any relevance? Everybody made up their mind about this issue long ago, and everyone agrees on it today. So really, what would have been the point of your study? So in the next section, I issue two challenges to this medical student. Your imagined RCT didn't occur to anybody at the start of the pandemic, and there's no one who actually could have run it had this idea oddly popped into their head in the spring of 2020. To be blunt, I think it's another sad example of what I call an impossible, unethical study of dubious value that's not meant to be taken seriously. There, I linked to an article that I wrote, I don't know, 7 or 8 months ago about doctors who are calling for a randomized controlled trial of several 100,000 or even 1 million children of the COVID vaccine. And there's just no way that study could have been done in less than a decade. And I call that, like I said, an impossible, unethical study of dubious value that's not taken seriously. That's not meant to be taken seriously. Back to the article, back to the letter. Since you disagree, I have two challenges for you, one for now and one for later. My immediate challenge is to write the protocol for your imagined RCT. I challenge you to write up the exact methods, the exact outcomes that you would be measuring, and the power analysis for an RCT that would actually have gotten IRB approval, would have actually gotten buy-in from the relevant stakeholders, hospital administrators, hospital staff, that actually would have been feasible at the start of the pandemic and would have used and would have given us actionable information in a useful time frame. Little deviation here, a power analysis is basically just how big the study has to be. So if you are looking for something with a giant effect, for example, parachutes, you don't need to enroll that many people to show that parachutes work. If you give 10 people a parachute, 10 people placebo, and you throw them out of an airplane, you're going to get a very clear answer with 20 people. But if you're dealing with nearly everything else that has a much smaller effect, positive or negative, you need to enroll more people. So how many people or how many hospitals do you think you would have to enroll? Back to the article. For reference, the protocol for just one of the pediatric vaccine RCTs was 460 pages of dense policies and procedures. You should read about it. I don't expect you to produce such a document, but it shows the enormous thought and effort that serious people put into designing an RCT, even a completely straightforward one, when they actually intend for it to be done in the real world. Moreover, RCTs are very expensive, and our public health agencies haven't been drowning in money. Quite the opposite, actually. You should read about it. And there I linked to a very depressing article showing that a lot of public health agencies had to use, local ones especially, had to use volunteers during the pandemic. I mean, they're chronically underfunded. Back to the article. Your trial sounds expensive. So in your proposal, please include an estimate of how much your study will cost, where funding should come from, and how this might have impacted funding for RCTs for COVID treatments and for COVID vaccines, things that I think were bigger fish. Of course, writing a protocol and securing funding, that's just the start, not a guarantee of success. Once those are done, the real work begins. Research staff has to be hired and trained. Hospitals have to agree to sign up. Subjects have to be enrolled. Outcomes have to outcomes have to be measured, and the data has to be analyzed and published. Running a large RCT is a logistical marvel with many moving parts and opportunities for things to go wrong. I suggest you listen to people who actually tried this pandemic. You could learn a lot. And here I quote from some researchers who were featured in a Washington Post article at the start of the pandemic. One researcher who actually tried to run an RCT said, "I think of what my clinical research team went through to enroll people in that trial, and I thought my nurses were going to die. One of them got COVID and got sick. Imagine trying to do that on a daily basis, multiple patients, some of them facing intubation, none of them having their families. A tragedy, we all agree." Another said, "There was one day our system had 84 deaths, and you're going to ask me to potentially put them on a placebo? It's just heart-wrenching to talk with families. If your patients are able to communicate and you're dealing with all of these deaths," that ends the quote. It turns out that actually running a large RCT in the pandemic is a lot harder than just imagining one. How would your study have overcome these obstacles? Not surprisingly, graveyards are full of dead RCTs, and there's research into why trials fail. You should read about it. And there I linked to an article about what goes wrong in RCTs. And this continued during the pandemic. An article from the Gates Foundation titled, "Uninformative Research is the Global Health Crisis You Never Heard of," said, and I quote, "According to a 2021 study of thousands of COVID-19 drug trials, only 5% of the study arms included enough people to generate a statistically valid result. Chaos is to be expected during a crisis like a pandemic, but the norm during peacetime is nearly as worrisome. A recent study of US clinical trials related to heart disease, diabetes, and lung cancer found that only 26% ended informatively. To put it bluntly, 3 out of 4 were a waste of time and money. Even trials they ran failed miserably during the pandemic, although it was much less complicated than your imagined RCT. A proposed RCT of hydroxychloroquine and azithromycin run by the NIH, the National Institute of Health, closed in a month after enrolling just 20 patients, or 1% of their goal. I'm sure that study looked great on paper. Why would your study succeed when they couldn't enroll more than 20 patients in the most basic RCT imaginable? Let's see what you can come up with. Let's see what your proposal says. Challenge number 2, and I will open with a quote from Winston Churchill. "I no longer listen to what people say. I just watch what they do. Behavior never lies." My second challenge for you is more long-term. I challenge you to avoid a lamentable career of merely writing blogs, imagining one impossible RCT after another, and then whining they didn't do the trials you imagined. Unfortunately, throughout the pandemic, a small number of doctors who've yet to make any contribution to an actual RCT have falsely claimed that RCTs and only RCTs can answer even the most basic questions, and that dozens of complicated RCTs could have easily been done if only they weren't so stupid and incompetent. These doctors never promoted an actual RCT. They never encouraged their audience to actually enroll in an RCT. Like you, they imagined the RCT strike force was real. And rather than do the hard work of advancing an actual RCT, they merely fantasized aloud what they would have done if they were in charge of the strike force. It's sad that these doctors are more famous and influential than the largely anonymous researchers who actually ran RCTs, don't you think? And a little pause here. I mean, this is true. I off the top of my head, I can't name people who ran the vaccine RCTs or some of the COVID treatment RCTs. I mean, maybe that reflects poorly on me, but these aren't famous household people. I can name a lot of people who made long lists of RCTs. And at this point, I'd link to an article by someone who goes by the Twitter handle Gurwinder. His name is GS Bogal, or hopefully, again, I'm butchering his name, so I feel bad about this. And he wrote an article about something called the opinion pageant. And I really think everyone should read it. He's a very interesting guy, interesting thinker. I've written articles based on his work before. But he defined in a tweet the opinion pageant this way: the rise of social media as the primary mode of interaction has caused us to overvalue opinions as a gauge of character. We are now defined more by what we say than what we actually do. And words, unlike deeds, are cheap and easy to counterfeit. Back to my letter to the student. Imagining impossible RCTs is a complete waste of time for a highly trained doctor. There is nothing less impressive. Do you really want your memoir to be titled RCTs I Imagined? I hope not. Instead, I challenge you not to sit on the sidelines, but rather to become they and to actually do the RCTs you imagined. You wrote, there are ways to uncover answers, and you made it all sound so easy. Soon, you should be the one uncovering those answers with RCTs. In the meantime, I suggest you use your voice to educate the public that RCTs aren't the only means by which doctors can learn about the world. There haven't been any RCTs of the virus after all. And here I link to a satirical article of mine saying we should do RCTs of the virus. Do you think that younger people have less risk from COVID than older people? Well, you probably do. You're right. But you didn't learn that from an RCT. Moreover, back to the letter, your statement that visitor restrictions caused significant harm wasn't based on an RCT, was it? You just knew. We can also make important decisions without an RCT to guide us. When we opened up hospitals again, no RCT proved it would be safe to allow visitors at hospitals. We just used common sense and collectively agreed that the harm of COVID patients dying alone exceeded the unknown risk, and it was unknown, of allowing visitors. This didn't seem to bother you. Yet, if we had clinical equipoise at the start of the pandemic, don't we still have it today? After all, your imagined RCT wasn't actually done. So, would you support doing an RCT today, even though it would mean that some families would be barred from visiting their dying loved one? Like you, people rarely demand rigorous RCTs to justify policies they support. I also suggest you use your voice to educate the public on the value of RCTs. Being part of an experiment is scary for a lot of people, yet medicine couldn't advance without willing volunteers. Being a guinea pig is a derisive term, but it really should be a compliment. Though it's not been the main focus of my career, I've tried to enroll patients in many different studies over the years, and it's not always easy. As you'll soon find out, many patients just don't trust they. Unfortunately, articles like yours give the public every reason to distrust they, meaning the actual people who actually try to enroll patients in RCTs. How do you think they feel when a medical student degrades them as you did? Do you think it makes their job easier? Do articles like yours actually advance the causes of RCTs in the real world? I don't think so. And this upsets me because I believe strongly in RCTs. Those of us who recognize we can't study every aspect of the pandemic via an RCT, we are not against RCTs in principle, as some doctors imply. And here, taking a little break, I linked to an article by Dr. Vinay Prasad, who essentially says, you don't understand evidence-based medicine if you're not willing, if you don't advocate for everything to be studied via an RCT. Back to the letter. It would be wonderful if running an actual RCT was as easy as simply imagining one. Because I want RCTs to actually exceed in the real world, I've encouraged people to enroll in them. Here's what I said in the very first article I wrote this pandemic. I wrote, I've always believed that people who participate in medical research are doing a noble thing. If no one volunteered for such research, medicine would never advance. I doubt that those two sentences alone convinced anyone to enter an RCT, but I suspect that if more doctors spread positive messages about RCTs and encourage people to actually enroll in them instead of just berating this would have had a positive impact in the real world. My dedication to RCTs is such that I've volunteered to be in a vaccine RCT. My contribution was a very small one. It took place in my hospital. I didn't have to leave, and they gave me snacks, and they gave me a little bit of money, which I donated to charity. I'm such a noble, wonderful person, a little sanctimonious. I get that. But my contribution, though it was a small one, at least it was a real one. And I want my actions to match my words. And so I don't feel like a complete backstreet driver when I agree that more RCTs should have been done this pandemic. The UK had something called the Recovery Program, and this was a model for what should have been. They did about 9 or 10, maybe more, I don't know exactly, but medication RCTs. And I actually think an elite, well-funded RCT strike force would be amazing. Until that exists, however, your statement that there are, quote, smart people in positions of power with resources that can design and conduct such studies was gross misinformation. Endless calls for someone else to run impossible RCTs of everything are just a way for the commentariat class to do what they've done the entire pandemic. That is to spread fear, uncertainty, and doubt about common sense measures to control a rapidly spreading virus in a world with finite time and finite resources. Doctors imagine impossible studies like hospital visitation RCTs, not because they actually want to get them done, but rather to sow doubt in the public's mind. They want people to think we shouldn't do anything until we know everything. None of this is new. Casting doubt on vaccines by calling for an impossible RCT of the entire vaccine schedule over the entire human lifespan, looking at every possible outcome, is one of the oldest anti-vaxxer tricks in the book. You should read about it. And there I linked to an article, which I think was originally written about 10 years ago by a psychology professor, I believe she is, Dr. Allison Haygood, who wrote an article called The One Trial. And this is because, as I said, anti-vaxxers frequently sort of say there's never been an RCT of the entire vaccine schedule. Sure, you can show me an RCT of the HPV. Sure, you can show me an RCT of the measles vaccine, but you can never show me an RCT of them together. I mean, she went through, kind of like I did, about why this, an RCT of the entire human, the entire vaccination schedule lasting the entire human lifespan would obviously be impossible. But that's the point. No one expects this sort of trial to be done. It's just there to cast doubt. Back to the article. Fantasies of impossible studies always end with some version of what you said, which is they failed us, and we are left without answers and policies that cause significant harm. In the real world, during a raging pandemic with a brand new virus, they had to make many difficult decisions without the benefit of a rigorous RCT to guide them at every turn. Yet, doctors who merely imagine RCTs absurdly claim that they have only themselves to blame for their predicament. Unfortunately, this was all part of a much larger trend where doctors with no real-world responsibility for anything made impossible things sound very easy in their tweets, editorials, and YouTube videos. As I wrote previously, and this is I wrote in the introduction to my book, shameless plug, we want them infected, but I wrote this. I wrote, in the imaginary world, all it took to protect nursing homes and open schools was to say, protect nursing homes and open schools. In the real world, this was impossible when the virus was allowed to spread freely, when impossible things could not be done effortlessly in the real world, they were always to blame. And here I have a quote by Dr. Jay Bhattacharya, who I think has really sort of mastered this skill of making very difficult things or impossible things sound very easy. He is one of the authors of the Great Barrington Declaration, and he said the following: not long from now, maybe 5 or 10 years, when COVID is widely seen as a bad cold, thanks to widespread population immunity, people are going to look back and wonder at the panicked overreaction. They will say, why didn't they just protect the vulnerable and get on with life? As if all it took to protect the vulnerable was to write, protect the vulnerable. There's nothing inherently wrong with just fantasizing how you would have handled the pandemic had you been given unlimited time, unlimited money, unlimited power, as well as total cooperation from the public with all of your imagined plans. However, you should recognize that this is just play acting, not a serious contribution. You see, none of us have to fantasize what we would have done during the pandemic. What you actually did the past 3 years is exactly what you would have done. And something tells me that if you are brave enough to devote your career to actually running RCTs, you'll no longer be impressed with doctors who merely imagine what they would have done while moaning, they failed us, because in the real world, actually running an RCT is a lot harder than just imagining one. And I will end with a famous quote from Theodore Roosevelt called "The Man in the Arena." It's not the critic who counts, not the man who points out how the strong man stumbles or where the doer of deeds could have done them better. The credit belongs to the man who is in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes short again and again, because there is no effort without error and shortcoming. But who does actually strive to do the deeds? Who knows great enthusiasms, the great devotions? Who spends himself in a worthy cause? Who at the best knows in the end the triumph of high achievement, and who at the worst, if he fails, at least fails while daring greatly, so that his place shall never be with the cold and timid souls who neither know victory nor defeat. Thank you for listening. Friends, this is my dog Dexter, and he is here to tell you that I made a mistake here. The vaccine RCT results were not released until the fall of 2020, or even early winter, not in the spring 2020. Obviously, that's when the pandemic started. Thank you, Dexter.